Hello, everyone. So my name is Alexandre. I'm an anesthesiologist from Erasmus Hospital in Brussels, but I work in Paris at Bicêtre Hospital. Before I start, I have to disclose my conflict of interest. I'm a speaker for these companies, and I've received the mentioned research grant. So the way hemodynamic therapies are delivered today in anesthesia and critical care is suboptimal. In the OR, hemodynamic management is mainly related to the administration of fluid and vasopressor, and we are going to focus on vasopressor, of course. Hypertension occurs frequently during surgery and has likely a negative impact on patient outcome. Indeed, several research groups have documented a strong link between intraoperative hypertension and postoperative complication. This is true for, of course, operating room, but also in the ICU, where we can see multiple published papers the past years. The importance of this topic is so hot that the major journals are doing the cover with this topic. Here for intraoperative and also for postoperative hypertension. What we also know is that targeting an individualized blood pressure management during surgery resulted in less postoperative organ dysfunction compared to standard of care. And the anesthesia community highlight the importance of the personalization of arterial pressure during the perioperative period. What we also know is that in this study by Wu and colleagues, they randomized more than 600 elderly patients with chronic hypertension into 3 groups, and patients randomized with a MAP target between 80 and 95 millimeter of mercury had less acute kidney injury than the 2 other groups. So what is the current vasopressor titration today? We analyzed more than 3,000 patients in the OR and in the ICU under continuous norepinephrine infusion. And we showed that in more than 50% of the case time, patient had a mean arterial pressure between 60 and 80. In more than 10% of the case time, the patient is in hypotension defined with a MAP below 60. And in more than 40% of the case time, patient had a MAP above 80 millimeter of mercury. This means that there is a room for improvement in the arterial pressure management of patients receiving continuous vasopressor administration. What we also know is that there seems to have a link between arterial pressure variability and altered patient outcome. So we developed, during the past 5 years, a closed-loop system for vasopressor titration. So closed-loop system is a system which a controller monitors one or multiple variables and adjusts one or multiple interventions using the feedback process. This is used, of course, in life with the regulation of hormones in our body, but also with the cruise control, thermostat, and we all know the self-driving car. In medicine, we have a lot of examples of closed-loop system for hypnosis control, nociception control, hemodynamic control, temperature control, and of course, we all know the glucose control. What we know is that closed-loop system, when compared to human management, better maintains a given target within a very narrow range and decreases overshooting and undershooting of a given target. Closed-loop control is not a novel idea. Back in the 80s, we could observe a lot of paper on closed-loop control, and we had an exponential growth since 2010. The first closed-loop control for vasopressor titration was patented in 1978. And today we can say that we have around 7 to 8 research groups around the world developing closed-loop system for hemodynamic control and mainly vasopressor administration in the United States, Japan, Singapore, China, France, and Sweden. So we also, as I said, develop our own closed-loop control for vasopressor titration, and we did extensive preclinical evaluation, so in silico studies, which is engineering studies in computers, and then in vivo studies, and we demonstrated that our system works pretty well with excellent performance metrics. What do we have in the operating room as human studies? Until now, we had 2 teams, one from Singapore, another from China, They develop a closed-loop system for vasopressor administration, but the main characteristics is that they use it in low-risk patients, mainly women patients undergoing a C-section under spinal anesthesia, and they use ephedrine and or a combination of ephedrine and phenylephrine to titrate vasopressor during surgery. So we decided to mainly focus on high-risk patients because these are patients who usually require a lot of vasopressor undergoing general anesthesia, and we focus our attention on norepinephrine infusion. So we started with our first proof of concept study, and we published it last year in the British Journal of Anesthesia, and we showed in 20 patients undergoing a wide variety of surgery and also in the ICU in the post-operative care of cardiac surgical patient, that patients spent less than 3% of the case time in hypertension and more than 2% in hypertension under norepinephrine infusion. Here an example of a major aortobifemoral bypass surgery, and we set the target at 70 millimeter of mercury, and we can see that patients spend 0% of case time with a MAP below 65. Here in blue, you can see the MAP during the case, and in red, you can see the administration of noradrenaline during surgery. Then we also tested this system in the cardiac setting, and we did a case report, in fact, a case series, showing that the system can work effectively during off-pump surgery, on-pump surgery, and also there is a mid-cap surgery. Then when we also know is that patients most of the time in the operating room don't require any arterial catheter. Therefore, we also tested our system with a continuous non-invasive arterial pressure device, here the ClearSight system, and we did it in renal transplant surgery. And finally, we tested our system in the ICU at Erasmus Hospital, here in a trauma patient, a head trauma patient, where you can see here the system, here the hemodynamic monitoring, the infusion pump, and the noradrenaline bag. So we have just completed this randomized control trials because all of the studies I showed you was pretty small cohort study without control group. So we went for a comparison between the automated closed loop system versus the standard of care, which is the manual control of noradrenaline infusion. And this paper has just been accepted in the British Journal of Anesthesia. And clearly you can see that patients in the closed loop group had significantly less hypertension during surgery compared to the control group. Then this is an ongoing study in Paris at Bicêtre Hospital. So we try to compare once again in a randomized control study design, the manual noradrenaline administration in brain injury patient. Here we record all the data. And in the other group, the system is going to administer noradrenaline under the supervision of the nurse ICU. Here the system, once again, with the infusion pump and the noradrenaline syringe. Then we are going to test in 2021 in a private practice in Lyon, in France, in 40 patients, once again, a randomized control trial, manual versus automated adjustments of noradrenaline. And the primary objective will be the percentage of case time spent with a MAP below 65 millimeters of mercury. This study is just completed, and we are currently writing the paper to submit it to a major journal. So it is individualized fluid and vasopressor management. In one group, the anesthesiologist had to follow our institutional protocol, which was to maintain the MAP and the stroke volume index within 10% of the target value. And of course, in the other group, a closed-loop system for vasopressor administration is going to maintain the MAP within a narrow range, and a decision support system here, the assisted fluid management system, is going to recommend the clinician when to give a bolus of fluid to maintain stroke volume within an optimal range. This is important because, as you know, just correcting hypotension with a closed-loop system for vasopressor titration is good, but what we know is that a low blood pressure can be due to vasoplasia, but also to hypovolemia. So next step for us would be to combine our system for fluid administration with our system for vasopressor administration into a unified, unique closed-loop system. This has already been done in Paris with a team of Jacques Duranteau and Nicolas Libert, where they developed a system which can co-administer both fluid and vasopressor simultaneously, and they tested this system into a small animal in a rodent model and then in a large animal model. Combining multiple closed-loop systems together is not new. We already showed in a brief pilot study that it's feasible to use multiple closed-loop systems simultaneously in the operating room. So the goal for us would be to go in this direction. And of course, the long-term goal would be to show that correcting hypertension using automated system can improve patient outcome. And in this study, we demonstrate that the use of multiple closed-loop systems to optimize fluid administration, end-tidal CO2, and depth of anesthesia outperforms manual management and may have an impact on cognitive function of elderly patients undergoing major surgery. If you want to further your knowledge into this topic, I strongly recommend you read these 4 recent review articles on automated system for hemodynamic optimization. I like to finish with this picture, is to say that when the case is going well, when the surgery is going well, of course, automated system is going to work very, very, very good. But we also know that during surgery, bleeding can occur. And then, of course, when it occurs, you can let the system work, but you have to override the system. And don't forget that we have seen many examples very recently that these systems are not meant to replace the clinician, but rather to assist them in the operating room. Thank you very much.